Hello, good morning, everybody. It's Jeremy Cox here. I'm in the leadership and OD team here at the King's Fund, and I'm chairing this session this morning where we're beginning to look at some of the emerging learning and developments around academies and their contribution to health inequalities and population health work. So welcome back to day two. We really hope that you enjoyed the sessions yesterday and you've been able to make the most of networking activities on the platform, have made new connections, and been exploring some of the interesting issues that will have come up for you yesterday. So this morning we're going to be hearing from our panel, and I'll get them to introduce themselves very shortly. And then we'll be answering as many of your questions as possible. So we've got a good chunk of time in this session for, rather than a Q&D, questions and discussions. And what we have is a kind of voting system. So there's a Q&A box here for you to engage with the session, and encourage you to do that all the way through, because questions might pop up for you right from the beginning. Post your questions in there and you have the opportunity to vote for the questions you think that resonate with you and you think you'd like. I'll be keeping an eye on those, and we'll hopefully curate the questions to get a variety of different topics covered, and obviously the most popular ones. And also just encourage you to engage with other attendees via the chat as well as we go. So without further ado, I'd just like to invite our speakers not to introduce themselves very briefly, just to say what their role is in the health and care system, and perhaps a little tiny bit about their experience with this topic. And then we'll get stuck straight into the presentation. So if I start with you, Andy, if that's okay, and then we'll come to Jason after that, and I'll cue everyone else in after that.
Great, sure. Good morning, everyone. Lovely to be with you. My name's Andy Knox. I'm a GP up in Morecambe Bay. I'm also Associate Medical Director for our ICB across Lancashire and South Cumbria, which is a population of about 1.8 million people. I'm an associate at the King's Fund and also at the Centre for Population Health. And I run and have co-founded our Population Health Leadership Academy in Langston, South Cumbria, which we initially did in conjunction with the King's Fund and have now taken in-house. And I'll be talking to you a bit about our development and what we've done along the way.
Andy, thank you very much. Jason.
Morning, everyone. I'm Jason Strelitz. I'm Director of Adults, Health and Communities in the London Borough of Newham, which is East London. I'm Director of Public Health. I'm also Director of Adult Social Services, and have worked with colleagues both in within the local authority and the NHS and a range of academic partners to launch the Newham Centre for Health and Care Equity, which is what I'm going to be speaking about with my colleague Anne today.
Brilliant. Thank you, Jason. And yes, Anne.
Good morning, everybody. I'm Anne, and I work with Jason in the London Borough of Newham, where we have been collaborating with community organisations and academics and council colleagues and the NHS to, as he said, launch the Newham Centre for Health and Care Equity, which is relatively new, and we'll be talking to you about that journey this morning.
Brilliant. Thank you very much. And last but not least, Sarah.
Morning, everyone. My name's Sarah Smith. I am a consultant in public health and Deputy Director for Population Health for West Yorkshire Integrated Care Board. This morning, I'm going to be talking to you about our Health Inequalities Academy, which is part of our wider Improving Population Health function in West Yorkshire.
Sarah, that's brilliant. Thank you very much. And just to say, I'm really, really pleased to be hosting this session, because I did lots of work with different clients and also with our policy team internally around population health and inequalities, and working across local authority, voluntary sector, as well as health partners as well. So I'm really fascinated with the subject and very interested in how we hardwire more kind of infrastructure around population health. And I know that academies is a bit of a catch-all, and one of the things that we will really helpfully explore today is it's not necessarily the label that matters, but the journey and the learning, and hopefully encourage you to really think about what's growing and what's being learned from our lovely speakers. So without further ado, shall we have a trip to the northwest and see what Andy's been up to? Interestingly, I have a personal connection to all three of your places. My dad was born in Morecambe. Done quite a lot of work many years ago with the local authority in Newham, and I happen to live in West Yorkshire as well, so I feel connected to all of you in a nice way. So Andy, over to you.
Thanks ever so much. Really, really cool. So I guess what I wanted to talk about this morning was the principles that underpin and sit under our Population Health Leadership Academy, or Population Health Equity Leadership Academy, depending on who you ask and who's naming it different days. The first thing is that we wanted to create time and space for people, right? So the work of population health and tackling health inequity is absolutely vital if we're going to shift towards new ways of working and being. But what we've discovered through many of our clinicians who've been through the program now, and also managerial colleagues, is it's been a huge missing part of curriculum in medical school, in nursing school, in AHP school, and people just haven't had their heads around, what does this mean, and how do I get into this work, and how do I do it in a way that doesn't feel like it's another straw to break the camel's back, but actually becomes integrated into my day job, and so one of the things was we are deliberately created time and space. So our first year of the program, we took 50 clinical leaders through from primary care, and we paid them a day a week to be there. And for some of them, we even had to pay backfill. So we had to put some financial investment in there to say, we believe in this. We're giving you time and space. And we've got a beautiful venue at the Health Innovation Campus at Lancaster University. And we bring people away for a whole day. We ask them to turn off their mobile phones as much as they possibly can, to not be on call, to really prioritize being there. And we just create really good time and space and environments for people to enjoy being together. The second principle is that we wanted people to rediscover joy. Loads of people came onto the course feeling completely burnt out, at the end of themselves, overwhelmed with the number of people coming through the doors of our EDs or our primary care facilities or into our outpatient clinics. And it's really hard to see the wood for the trees. So we wanted people to reconnect with joy. And actually, that's been some of the best feedback we've had, is that people have said they've rediscovered joy in their work as a result of being on this program and learning to work differently. The third thing is that we wanted people to have time to connect with core purpose. I don't know how many of you are Ted Lasso fans, but one of my favorites is one of the penultimate episodes in season 3, when Ted Lasso, the American coach of this made-up football team, Richmond FC in London, he has a real conversation with Pep Guardiola, the boss of Man City, which is painful for me to talk about as a Man United fan, but there we are. So anyway, Ted says, they're having this conversation, and he says, how is it that Man City are always so amazing? And Pep Guardiola responds to him and says, it's not really about the winning or the losing. It's about the quality of human being you have on and off the field. And so we actually believe that one of the core principles of population health and tackling health inequity is to get to the why. So the economist Mariana Mazzucato, she says that really society is a manifestation of our values and who or what we value. And so the truth is that health inequity exists because we value some people in our society far more than we value others. We value some communities far more than we value others. And the values which underpin the ways in which we work with those communities need a bit of a shake-up. So we unashamedly do quite a lot of internal personal work, and we do quite a lot of reconnecting people with core values, core purpose, why they came into this work, why they care about it, what the truth is around social justice. And we want them to feel a sense of passion and compassion about this work, so that it motivates them to begin to work and think differently. Another principle that underpins this is what we call gift economy. So the ICB pays for it, funds all of it. So no matter which organization you're from within our ICB, whether it's a hospital trust or primary care or the mental health trust or whatever, we fund your time to come on this course, and we fund the course for you because we believe in it. And then because we're talking about gift economy, we're looking for reciprocity of gift as people then move on into their work in the future. And we've seen phenomenal projects develop. So every person who comes on the course starts working on a health inequity project as part of the course, and they're coached in it through action learning sets. And then we've got beautiful stories right across Lancaster and South Cumbria. So 50 primary care leaders through it now, 50 leaders through from secondary care and mental health and community services. Next year, we're launching our first ever executives program, where we've got board members from our trusts all coming on this together, which is going to be really exciting, and a senior leaders program. So it's really developed. I'm just going to very quickly share with you one slide. Have I got time? Yeah, one slide just to kind of show you the flow of our program. And is that working? Is it showing? There we are. So that should be sharing now. So just kind of to talk through the flow of the program through the year, we start with, why does health equity matter? Why should people care about this in the midst of all the busyness? But you can see that then we involve straight away, who are you as a leader? What does it mean for you in this space? How are you going to deal with your own ego structures? How are you showing up into this? What does it mean for you? We then talk about complexity and kindness, and then through to thinking about compassionate leadership, how we really take an improvement approach to this work, working with the IHI. What about the power of community and community power? How do we work with that? Thinking about primary care, particularly for those who are in secondary care and don't really understand how it works. We've got some amazing stories up here from Fleetwood. We also work with the Bromley by Bow team. And then we think about inclusive leader. Yesterday, we had this beautiful, provocative, difficult session on stigma, racism, and me, and what that means for us as leaders. Then we think about integration and how we work well with public health and with the community voluntary faith sector. And then we do a kind of celebration event and use something called the eco cycle. So we get speakers from around the world helping us on this program. It's a really wonderful thing to be part of. And the feedback and the things that people are beginning to do together as a result have been really, really exciting.
Andy, that's fabulous. Thank you very much for that input. And the shape of the session is we get an overview, a provocation, some insight from our speakers, sort of 8 or 9 minutes, and then we'll have plenty of time for Q&A and discussion at the end. So this is just to get us kind of going, and I can see already that we're starting to get some questions coming through, and I'll keep an eye on those and hopefully get as many of those addressed as we can. So without further ado, shall we travel to the lovely East End of London, to the borough of Newham, and let's hear from Jason and Anne.
Great, thanks so much. Anne, are you going to share the slides? So it's great to be here. As mentioned, Newham is a borough in East London, an amazingly dynamic, amazingly diverse place. Nearly 75% of the population from ethnic minority communities, significantly young population, growing old, very vital, but significant levels of poverty and deprivation. And the journey here really begins in the pandemic, where although we worked on health inequalities for many years, that thing that many of us experienced, which was seeing the impact of health inequalities in data, really play out in the day-to-day experience of the levels of morbidity and mortality we were seeing in our communities. And particularly in Newham, we had one of the highest standardized mortality rates when the ONS first published data in the aftermath of the first wave, and really reflected deeply on the way in which policy nationally and practice locally had or had not worked for our communities. We looked at the way when testing was first introduced, it was introduced for drive-through test sites, and over half of our population don't have cars. We looked at shielding guidance and thought about our population, where so many people work in roles out in the community where they couldn't work from home, in retail, in transport, in security and other roles, and live in multi-generational households, crowded multi-generational households, and therefore people who were the guidance would say should be shielding, but actually it was impossible for them to do so. And we looked at our own communications and realized how we were not reaching parts of our community through our own communication. So we started to ask much more deeply, how do we ensure that policy and practice works for our population? And that was a guiding principle through the pandemic. And then as it emerged, we wanted to work much more closely, and we found academics wanted to work much more closely with us on that. Next slide, please, Anne. So we started to ask that question, how can we work together as a place, the local authority, public health, and other parts of the local authority, our health service, our community organizations who are now part of our collective journey, and our academics, to really learn and think much more deeply about that impact of policy and practice locally, and how we can ensure that it much more meets the needs of our local population. And since we started this journey, there's been such enormous interest and capacity and energy around this goal. Next slide. So we launched the Centre of Health and Care Equity, and with a clear set of aims. The number one is we want to generate actionable insight for how policy and practice can promote health equity at a local level. This is about that fusing of all of the stuff that's happening, the millions of pounds being spent in our health and care economy locally, with the appetite of academia to know about what's working, how to make it work as well as possible to generate meaningful insights. It's about enabling that collaboration with all of the parts of the community that I've mentioned, that shared common purpose around health equity. It's using that learning that we generate to inform decision making, to work with our local politicians and other senior leaders to learn to influence change, and then to use that to inform change much more widely. And there's a real principle at the heart of this, which is ensuring our communities of Newham are very involved in this process. This is not about doing to, this is about collectively working on with. This is about a collaboration between, and it's really building on, all kinds of brilliant work that's happened as a place, both before, but really, really transformed during the pandemic, and keeping to build on that, and really bridging that desire of academics to do research which that drives meaningful change, with our also desire to really promote health equity. Over to Anne.
So one of the things that Jeremy said to us in the briefing for this session is that it's quite useful to know kind of how we're actually trying to do this. So the way that we are approaching the delivery of the aims that Jason has set out is with 4 work streams. So the first of these is about embedding academia and local practice, but equally embedding local practice in academia. And as Jason said, one of the things that we learned really powerfully during COVID, and we're seeing in other things like, in particular, like the cost of living, is that we need to be listening to, partnering with communities to ask the right questions at the beginning to even get our practice correct. So we are quite explicitly trying to bring both of those into each other's realms. Then the second thing is to be co-delivering evidence-formed and evidence-informing practice. And again, it's about this being very conscious about a two-way interchange between things we know and evidence we have, which is powerful and deep and useful, and continuing to learn, particularly in places where perhaps we haven't done as much research or have as much evidence about what does or doesn't work. And then the third bit, which is, I know, the overarching sort of theme of the conference, is using that to improve equity in services specifically. So how are we making sure that the delivery we do is accessible, is relevant for people, is trusted, and is therefore improving the equity of experience? And then finally, I was listening to Andy, and I was a little bit jealous, Andy, of the things that you have to create space and a pretty build and a lovely space, a building. And so there's both sort of emotional and practical space and actually physical space. We're co-creating a center from energy, commitment, relationships, and a little bit of resource. And it's starting to happen. What are the mechanisms that allow us to do the other 3 work streams? And then the other thing that's really important for us, and we're partnering, at least in the first year, with the London Research and Policy and Practice group, is what can we learn from our process about how we're working together, and therefore what impact are we actually having against the ambition and the aims that Jason set out. And as Jason said, one of our ambitions is to influence our own practice, but also to influence the context in which we do population health. And so really trying to understand where we've had that influence is part of what we're learning. We have created some collective leadership. And again, this is born out of passion and energy and excitement. So we're going to have an advisory board we're setting up an advisory board that will link the work that we're doing back into the institutions more broadly and back into those places of influence, and then a delivery group. And back to Andy's point about reciprocity and resourcing, we are seeking community organizations and community members, and we will be remunerating them and paying for their time and supporting their participation, as you should in best practice in this kind of collaboration. So I thought we'd give a couple examples. Am I okay for time? I can't see faces, so my watch says I'm okay, but Jeremy, am I all right?
I'll come off audio, yeah, just another couple of minutes, Anne, if that's all right.
Great. So we'll give you a couple of examples of what's happening in the center already. So the first example, which I think is quite powerful, is as a public health team and as a health economy in Newham, we funded a piece of discovery work on South Asian women accessing emotional support for their emotional and mental well-being. And that project, which at the time didn't have any academic involvement initially, ended up collecting a level of data we never expected. And we have then been having conversations, in this case with University College London, about fellowships. And we've now got a fellow from UCL working with that community organization to delve into that data in much more detail and a much more sort of rigorous way with a different set of skills than the community organization has or than we have in the council and the NHS, which will give us even more information on which to influence our practice. One of the challenges at the moment is how you set up a project in the beginning to then meet academic requirements about things like ethics and those kinds of processes that the academic institutions are rightly sort of bounded by. And then one other example, I thought, Jason, we would just skip to the one on household overcrowding if you want to.
Sure. So obviously we're highly rooted in the determinants of health. So another example of a project we've launched is around household overcrowding. We have the highest level of household overcrowding in the country, huge challenge. So we commissioned a relatively small piece of a very small piece of work from London School of Economics to identify practical and measurable steps to reduce the health and social harms associated with household overcrowding. And that research was all about working with our local authority, NHS, community organisations to understand that in a very practical way. They did the initial piece of research that led to a multidisciplinary, a multi-partner workshop on mitigating the impacts of overcrowding, and that work continues. So what are the things, even in the resource constrained context that we're working, what are the things that we can be doing, the practical steps we can do and it's a shift in emphasis. Often the academics historically have focused on describing the problems of household overcrowding, on talking about the need for more housing to solve the problems, something that we are just, not in the immediate future able to have a massive impact on. So it's a shift in emphasis to that aim of actionable insights. How do we collectively bring our different perspectives, the academic alongside the council, NHS perspective and community perspectives, to develop actionable insights, things that we can practically do to enable change. So we're at the early on in this journey. We've got a lot of different projects going. As Anne said, we're doing this on a shoestring. This is about building partnership based on the work that's currently happening in a way that meets all of our collective aims. We found academics really up for this. We've got some research fellowships starting with academics coming to work in the local authority to move forward in some areas. We're building our system for linking interested academics with interested practitioners so that people can start working together early on in the life cycle of projects. And we're really excited about where this is going to take us. Just to say, we've not mentioned specifically, but working really closely, particularly with UCL, the University of East London, and Queen Mary University of London, who are our three local universities, but working more widely as well. Thanks very much.
Jason, and that's fabulous. Thank you very much indeed. Some really interesting questions brewing up in the Q&A panel for me to bring to you all later. But I really love the intentionality about what you're doing and how you're really being systematic, not just about taking action, but learning from that and spotting the patterns and thinking about how you grow what you're learning in that very active learning space. So without further ado, let me just come off mute. Sorry about that. Sarah, over to you.
Hello, morning everyone. I will just bring up my slides. Hopefully you can see those. So hello from West Yorkshire. Today I'm going to be sharing our journey to our Health and Equalities Academy, but also kind of some of the things that underpin that as well. So I'll kind of touch on a bit of the nuts and bolts about what the Academy is, but really as well some of the principles of our kind of journey to get there and where we're going next. So I work in West Yorkshire. It's a population of around 2.4 million people over 5 places. So I work for an integrated care board. With that comes lots of complexity, lots of system partners to work with, but also lots of opportunities to reduce health inequalities. In the population of West Yorkshire, on average, our communities rank more deprived than the national average. And we've got a lot of diversity as well, lots of inclusion health groups that we work with. So again, lots of opportunity from a population perspective to do some really good work on inequalities. And similar to what we've just heard, we'd set up an improving population health programme just before we went into the COVID pandemic. And these are the sort of key areas of the programme which the health and equality space sits within. The reason I've shared these is the work we do on inequalities is underpinned by all of these other elements of public health practice, and none are independent of each other, even though we're talking about the health and equality space today. As we were kind of coming through the pandemic, and we were trying to harness the interest that people were having around health and equalities, but also create that space for people to learn more and take action in the areas that they were working on. So we talk a lot about what's in people's direct circle of control to work on in health and equalities and what's within their circle of influence. And our Health and Equalities Academy provides different interventions for people to kind of really build on that. So our overall approach for health and equalities has got 3 elements, of which the Academy sort of feeds into the capability space, which I'll touch on. But we're also have a real focus on bringing additional capacity into the system, additional resource to focus on health inequalities. So in early 2022, we invested £1 million of NHS monies on winter warmth. So that was monies that would have been spent in some of our hospital trusts. We decided to invest, and we're evaluating this at the moment, in actually fuel poverty, with the idea that actually if we get people warmer in their own homes, we'll reduce the impact on NHS services as well. From a capacity point of view, we've also been able to ring fence nearly £11 million of our core 20+5 funding to work on health inequalities. And 80% of this has gone directly into service delivery in local communities and local places. And then the remaining 20% has helped us do some work at a system level on the Health and Equalities Academy, and also on an inclusion health unit, which we set up this year as well. So in addition to the capacity and the capability that I'll come on to, we've also got a really big focus on intelligence. So how do we use the data and the insight and the conversations with communities that we've got to really drive forward changes and reductions in health inequalities? So there's some examples on the screen of some of the reports we've commissioned around health needs assessments, work with women and girls. But this is kind of an ongoing theme that we run through the Academy and run through the health inequalities work that we do in West Yorkshire. So if I move on to the capacity space and come on to our Health and Equalities Academy, the Health and Equalities Fellowship that we've got, Health Equity Fellowship, is really the flagship project, I think, of the work we're doing in the Academy, and something that we're really proud of. So we set this up in 2022. The idea was, we knew there were so many people from the work we'd started to do on health inequalities within the system that had ideas for projects they wanted to work on. They wanted to know more about what they could do, but they didn't have the space or the time to do it. So we approached our exec leads and we said, look, we've got this idea for a Health and Equalities Fellowship, Health Equity Fellowship. what we need from you is people's time. We want to kind of offer this out to the system, but what we'd like in return is you to be able to free up people if they're successful and getting on 1 day a week of their time to come on the fellowship. And we were really well supported by exec leads, and they said, yes, go ahead. So we were able to launch the first Health Equity Fellowship back in 2022 with quite little resource. We did backfill for voluntary and community sector spaces, with the acknowledgement that there was less funding in that part of the system, and people kind of needed the resource in order to be released to do the work. And we started the year in 2022 with 30 health equity fellows, and we've now expanded to we've 132 fellows over the last 3 years. And we've expanded the fellowship from health equity to also offering spaces looking at adversity, trauma resilience, suicide prevention and climate change as well. Because again, we were hearing from the system that people wanted more headspace to focus on these areas. And what people get is 1 day a week of protected time to work on their project alongside some academic input and support from the University of Leeds, which is an accredited course in public health. We got that funded through our local School of Public Health, so we've got really good support from them on this as well. But they also get mentors, so they get mentors from within the public health system. And actually some of our previous health equity fellows have now gone on to become mentors for our current fellows in the programme. So there's a real good legacy there. And we have a lovely graduation event and some excellent reports that the fellows produce to influence future practice. That kind of feeds into our sort of intelligence model as well. In terms of who we get on the fellowship, it's really varied, and that's kind of the beauty of the approach, really, because there's a really good opportunity for people to learn from each other. So we have lots of clinicians on the course. We have people from voluntary and community sector backgrounds on the fellowship. We've had people from our housing associations, faith leaders, elected members. And on the bottom right of the screen there is our chair of the ICB board, who was one of our first health equity fellows, who obviously we couldn't say no to, Kathy Elliott. And Kathy did a project around economic growth and employment, education and skills, and anchor partnerships for our integrated care board, which actually has now really gone to underpin some of the work we're doing. And she produced a health and wealth framework for system leaders on the back of that was shared nationally. Another couple of examples on here, Emma Pears, who works at a local charity supporting children and young people with mental health conditions. The fellowship gave her the time and the headspace to further develop that, make some system connections, and gain £85,000 of funding to support her work on reducing inequalities for children and young people with mental health conditions. And then a bit more of a traditional project in the top right was around diabetes weight loss programme, particularly focusing on South Asian women. So this is just a bit of a flavour of 3 of the 132 total projects we've got as part of the fellowship. But like I said, it's something we're really proud of and something that's given people the headspace to work on that, those inequalities approaches, and really kind of upskill the system as a whole on health equity. Another couple of bits that we have as part of the academy, we have a resource hub online, which I'm happy to share the link to. We work with a charity partner called Fair Health, who are a fabulous charity. I'd point you in their direction as well. And they've got some resources that you can access online for free. And one of the modules we co-produced with them was around health inequalities in secondary care, because that was coming directly to us again from our secondary care clinicians, is what can we do to address health inequalities? How can we learn more? If they didn't have the time to do the fellowship, but actually have the time to kind of bob into a 15-minute module on what they can do in their day-to-day practice, then we wanted to produce something from, and that was this resource. And another thing that we're proud of at the moment is our inclusion health unit, which launched this year. And again, that's for us to give the headspace to work at scale on these population groups who are sort of small in number but great in need. And again, I think for us as a 2.4 million population, that's the beauty of coming together as an integrated care board, is to be able to have the headspace to work at scale on some of these population groups. And again, one of our next steps is working and partnering with Fair Health on some inclusion health specific resources for some of our local communities. So just finally, another one of the elements of the Health Inequalities Academy, which goes down really well, is we have an annual event. So the first event, as you can imagine, we were still partly in COVID times, was online, and we had some fabulous speakers. It was closed by Lord Victor Adbawali. People were clapping and in tears, and it was a really, really motivating event, and we got lots of lovely feedback, and we also got lots of good engagement and people really interested in the health inequalities space. And for me, being able to share some of those public health skills that I think when you're consulting in public health sometimes you take for granted, and to get some of that back out in the system was fabulous. And I think with the health equity and the health inequalities academy work, the more I can do to almost put myself out of a job and get everyone else upskilled in the system, the better, really. And our most recent event was the first one we were able to hold face-to-face, and we held it in a local community centre in Bradford, brought people together in the room, and we opened it with a lived experience story, which I'll finish with now. And it was a lady called Wan who arrived in the UK, having been a midwife in the country that she joined us from, and she's had a really hard time as an asylum seeker, both from a health point of view but from social point of view as well. And we heard about some of the things she was talking about that we'd badge in the NHS as sort of cultural competence in services and tailoring services according to need, but essentially we're just around kindness and compassion. And that was some of the learning that I think bringing everyone together as in the room to hear those direct experiences as part of the Health Inequalities Academy is something, again, that I think is really valuable, and I'm really proud we're able to do as a health and care partnership. So thank you.
Sarah, fabulous. Thank you very much indeed. And thank you to all of our speakers for your insight, knowledge, inspiration, provocation. It's fab. Got some really interesting questions coming through. So without further ado, I'll jump in. We've got quite a few questions, so I just invite you to try and be concise in your answers. And I know this is going to be very difficult because I can already tell we could literally spend all day talking about this and exploring even one of the questions. So without further ado, and I'll start with Andy for this one because this was a question from Claire, but I want everyone to come in and have a little kind of give us a gem. Claire was asking about what steps you took to help people rediscover their joy in work. So kind of what was the essence of kind of what you focused on or did around that notion of joy in work?
So I think a couple of things. One is actually creating time and space for people and helping people realize that they're important and they can breathe, and allowing people to just check in and build relationships and have the space to think and have the space to know that they are valued. And that brings joy, right? So actually creating the time and space alone is something that does that. The second thing is we had so much of our academy is based on getting to know your community. So very similar to kind of the Nuka model in Alaska, we believe relationships are the core of everything. And so actually encouraging people as part of their homework, go have a coffee with your local head teacher. Go find the anchor person in your community voluntary faith sector who has loved your community for the last 25 years. And we had GPs feedback to us, for example, that they'd sat in their clinic room for 15 years and had never once wandered out of their building to wonder who their community were. Now, as a GP, I honestly found that quite surprising, but with that, just curious about it rather than judgmental and kind of like, okay, how interesting. But what's been amazing is to see people just build relationships with people in their own communities, hear stories, be changed by those stories, and have rediscovered that actually their work is not about the 9 to 5, all the people coming through the doors of all the people they have to help, but actually building a totally different kind of coalition, learning to deal with community power differently, and learning to step outside of their comfort zone and do different things has been about building joy. Plus, we also teach a whole thing on cultures of joy from the IHI evidence and helping people understand how they become part of like deliberately creating those kind of cultures in their own workplaces, their own situations. So time and space, some real practical teaching on how you do it, and then actually creating the conditions in which they build relationships and rediscover joy through the joy of being part of community and realizing they don't have to be the heroes who fix everything. They can be part of a beautiful community doing it together.
That's lovely. Thank you, Andy. And I guess I'll pose the question slightly differently to Jason and Sarah. Maybe, is there anything you're noticing in the work that you're doing about sort of joy in work emerging for people?
So I'll share one thought. Thanks. I think, and it builds on really what Andy's talking about, but for all of us who work in public and community service of different sorts, we doing difficult jobs in a challenging world and system, feeling like you're part of something bigger than just your bit of the jigsaw is something that helps give you a sense of purpose and meaning and build that sense of purpose and meaning. And I think the events that we've done as a centre, which have brought people together. For example, we worked with UCL to invite all academics who are doing research in Newham together into one space. It was amazing how many people came to this event, most of whom all academics at UCL, most of whom had no idea about the work that their colleagues were doing in the borough. All of it because you can't work on health and care issues in Newham and it doesn't have a thread of inequalities running through it. All of it with commonality, but all of it working individually. And the really strong sense of actually, this is brilliant. We're coming together and we can learn from each other. We can share experiences and we can be, we all have our own research areas, but there is such a strong thread which brings together everything that we are doing. So it is building that sense of common purpose, both within institutions and across institutions, which I think gives real meaning to people.
Yeah.
Thanks, Jason. And what I would add to that is there's also a kind of medium and long-term contribution. So a lot of what we do is how are we responding to things today, and how are we dealing with problems today, and how are we and to have one of the things that somebody said to me recently is that universities are around for a very long time, and whilst sometimes we feel like they're going a little bit slowly, actually there's real value in that institutional longevity. And so there's this, like Andy said, there's this space to step back from the kind of every single day running. If I don't keep going, I'm going to fall off and hit my head, and say, what are we doing to prevent some of the problems that we're responding to today being there in 2 years, 5 years? And the other thing I was interested in this idea of who, Andy, you were saying who we value and who we prioritize when you were talking about health inequalities. And I was thinking, well, who's the we, right? Like, who's the we in that conversation? And I think the other place that people are, my observation and experience is that the other place people are finding joy is we're broadening this we. We're broadening who it is who makes decisions about priorities, about insights, about ways of responding to challenges and health inequalities. And that's joyous because that has impact in preventing those health inequalities from lasting forever.
Thanks, Sam. Sarah, what are you seeing? What are you feeling?
I mean, very similar themes, but I think the joy comes from having that space to think the longer term and to get some hope. So I think there's joy in having a bit of hope, in stepping away from the day job, having the headspace to work on the stuff that you feel might make a difference, but you don't often get the time to really work on, really think about, really get the skill sets to develop. And I think part of this academy type approach, however you frame it and however you define it, is around creating that space for people to do the things they're passionate about in terms of health equity, take a break from the day job and give them some hope, which in turn will help with kind of joy in work and resilience as well.
Thank you. So I want to shift the focus slightly to community. We've got a couple of questions which, given the time we've got, I think I'll cheekily crash a couple of questions together. We've had one from Nadia earlier on, which was really asking about members of the academy or the courses that you're running or the interventions. So this is it sort of started with a question for Andy, but I think it applies to everybody. are the people that are getting involved in these programs of work representative of the general population and the local community? And then there's a question that's come in from Annabelle, which was thinking about what does sustainable and sensitive community engagement look like, given that, you know, there's lots of engagement going on, but sometimes it's more superficial, perhaps. So how do we make sure that we're not kind of wearing out or disempowering our communities in the ways that we're engaging with them? So just really quick kind of headlines, because I want to get a couple more questions in. And what do you think the essence is of building properly representative programs of work, and your kind of key insights on community engagement? So this time I'll start with Sarah, if that's okay.
Yeah, thanks, Jeremy. I mean, I think from a practical point of view, certainly with our fellowship programme, we've been quite clear that we want the membership of the fellows to be representative of our local population. So we've explicitly sort of recruited in that way, because we know a more inclusive leadership approach creates space for reducing inequalities. I think in terms of that sustainable and sensitive sort of community engagement, and how do we support that at the moment, we do a lot of our community engagement work with voluntary and community sectors, particularly on kind of our inclusion health groups, because they're really best placed to have some of these conversations with the groups that we're working with, because they've got those trusted relationships. So I think a lot of it is around having the space to build trust. It's around kind of the principles of community engagement in then letting people know what they've contributed to. So creating that space to close that kind of feedback loop as well. We're working on an inclusion health community board at the moment, where we're getting voluntary and community sector reps, but also people with experience on that board. But when you're looking at people from extremely diverse backgrounds with potentially quite challenging backgrounds as well, that is something we're working through at the moment, and we've not cracked, and we've not we're looking at, you know, how do you bring people together who are from gypsy and traveller backgrounds, people with drug and alcohol use, people with prison leavers. You know, we're creating this term inclusion health, but how do you create, you know, bring people together in that safe community space? So I think it's something we need to be really conscious of, and we need to be really conscious of how that feels to the people that are being engaged with. But something we, you know, obviously need to prioritise as well. So definitely don't have all the answers.
Thanks. So the other panelists, just invite you to kind of jump in if you've got something to add. You don't have to add something, but so I can get a couple more questions in, try and make it, what's the essence of your insight?
2 points. One is that I, at least, and we're not talking about things being truly representative anymore, because that's sort of impossible. That actually we're talking about diversity of voices and diversity of perspectives. That's what we're trying to bring together, rather than expecting one community group to be representative of every community in a place. And the second point is that if you share the problems and you bring together the different resources from different partners, different capabilities from different parties around something communities care about, then energy remains. If you do it on something that the system decides, or the NHS decides, or the local authority decides, then of course people are going to get exhausted. But if you do it on a challenge that is something that community organization, those community organizations, those communities are passionate about, that's their energy.
Thank you, Anne.
Yeah,
Andy, quick thought from you, then I'll move on to another question.
Very briefly, two things. We've really appreciated some kind of co-learning in this space. So we really love the approach that West Yorkshire have taken. And together with our public health directors, this next year, we're going to be launching a separate leadership academy, which looks a little bit similar in terms of community involvement, community voluntary faith sector involvement, public health collaboration. To be honest, we've been unashamedly pushing the fact that, so our public health directors, when we had this conversation about 5 years ago, they said, you know what, could you get the NHS house in order before we'd start collaborating in different ways? So we've unashamedly got a very, very NHS-focused population health leadership academy, because actually we want our clinical leaders and our managerial leaders in the NHS to step up into this space in partnership and learn to work differently. But the way that they work is embedded in ideas like Poverty Truth Commission, the Truth and Reconciliation Council from South Africa. So it's very much about unlearning the traditional way of, hey, we're in the NHS, here's a project we're going to do. It's actually embedded in what is the data telling us? But then when we go and share that data with our communities and build really quality relationships and listen at a profoundly different level in which we are then changed, how do we then, with our communities, co-design new solutions to the issues our communities are actually facing, rather than the ones we think they're facing or the services we're currently providing? So yes, it's hugely representative of our communities because we are learning to work in radically different community power-based ways with our communities, but we're also unashamedly trying to change the culture of the NHS and the ways that we work within it. This next year, we're going to be co-developing a new academy program with our public health colleagues and our community voluntary faith sector leaders to create something a little bit also akin to what West Yorkshire have so brilliantly led also.
Andy, thank you very much. So what I want to get you thinking a little bit about sustainability now. There's been 3 or 4 questions that relate to this. And again, I'll hopefully you'll forgive me for just trying to bring some of the questions together. Linda was asking about the views on sustainability and moving from initiatives, kind of experiments, creating time and space and working in a different way. How do you move towards sustainability so that the insights and interventions and changes that are emerging from the work become hardwired and part of the way we work? We also had a question from Mena in Wales, thinking about do you have a focus on sort of long-term thinking and the future, and so in the work that we're doing today, how are we starting to build the future as well with some intentionality? And I think there's another question that's sort of relevant to this that came from Sarah, which is from Claire, and it was sort of directed towards Sarah, but I think it's an interesting provocation in this space around sustainability, where Sarah was asking how do the projects that the fellows do with you in West Yorkshire turn into something sustainable, or how do they get hardwired into the system? But again, we haven't got masses of time. Just encourage you to be brief, but give us a kind of your nugget on sustainability and how you're creating the future simultaneously with developing effective interventions in the now as well. So should we start with Jason this time, and then we'll move on quickly. So what's the essence?
So we're doing it right now on a shoestring, which is really hard. Like, we haven't got things like HDRC funding and things like that, or big pots of money. But one of the benefits is it means we're not doing lots of new stuff. We're trying to build a culture. We're trying to do it through a culture and relationships and values. And I think that's how we see it sustained. This is about making this way of working core to people's day job. And both from an academic's point of view, the academics who want to have impact, seeing the asset that is the local place system for them, and all the practitioners in our local system who are wanting to have greater impact, seeing the benefits of those collaborations. So it's about culture and relationships, and we think that is sustainable. We wouldn't mind a bit more resource to try and drive this along, but cultural relationships is what we're trying to create and what we're trying to address, and that's how we see sustainability.
Jason, thank you. And I think we won't get through all the questions, but there's some other questions about financing and resources, and I think we've heard some really interesting stuff. And I think they go together, from Sarah, for example, around how at a system level there's a reallocation, intentional reallocation of resources, as well as working on a shoestring and working with the energy and enthusiasm, and both of those things are necessary and inform each other. I don't want to resolve that, but I think it's really interesting that we notice that those things are going on and are both really important. So Andy, you look like you're ready to jump in.
just two things. It's interesting when you talk about sustainability. I thought we were about to jump into a conversation on climate change, and I'm co-hosting a day today next door with one of our directors of public health on climate change and population health. So I thought it was going to be about that, which I was excited about. But in terms of sustainability and momentum, I think hard baked into there are three things. One is, I think you've actually got to continue to give people funded time to do this. So you've got to build it into budget strategies and argue your case and help people. This cannot be something that feels burdensome. It has to be, you have to create space and time for people to do it in their work. The second thing is that you build momentum by building social movement. So Valerie Fournier's work on social movement, you create outrage, you challenge inevitability, and then you build moral alternative economies. So that's what we're doing. We're making people feel outraged about the inequity across Lancashire and South Cumbria. We've got the poorest town in England, poorest two towns in England on our patch. We've got, we want people to deeply care about it. We want to challenge the inevitability of their thinking that it has to be this way, but then we want to create moral alternative economies in which actually this becomes part of how we do it. And then the third thing is the building of momentum, I think, alongside that is because we've got a program which I think is now nationally recognized as being really good and people want to be part of it. We've taken 50 primary care leaders through, 50 secondary care leaders, and suddenly our board members are saying, we want to do this program because we want this to be sustainable through all of our organizations. We want to change the way our organizations run. That's an amazing opportunity when you've got like your chief execs and chief finance officers and chief operating officers of trust saying, we want to be on this course, we want to change the way our organization runs. And as that then begins to bed in, you've then got the scalability across the system to see things really exciting happen in terms of
Andy, and I think there's a real analog, isn't there, between that process of outrage, challenging the inevitability, creating the moral alternative that applies to climate change, as well as health inequalities and population health. I think there's a real analog there, actually. It's very transferable. So we've literally got a couple of minutes. So this isn't going to be easy, but a one-word answer, which might turn into 2 or 3 words. But there's a final question that we've had from Helen, which I think is really interesting, and a slight change of gear. And she's saying, as a lived experience leader, VCSE founder, Core 20 Plus ambassador, she's working on building a consensus around focusing on health and well-being rather than a specific thing like weight. So rather than targeting a specific illness, issue, topic like weight, how are we beginning to think about perhaps more holistic interventions? And it's a bit of a polarity between managing wider issues of health and well-being versus specific topic. And just any really quick sort of insights into that, and then we'll close out. So just if any of you've got anything to offer around that.
I think from a public health perspective, we'd all probably tell you the proportion of which your health outcomes are impacted on the healthcare interventions are really small, like 20%, and 80% everything else. So that's absolutely the sensible way to go. And that's again what you hear from your communities, isn't it? People want safe place to live, they want something to do, they want someone to love. And I think that kind of whole wellbeing approach is absolutely where we need to get to. And in terms of that, getting people interested in health equity, for us in turn has got people interested in adversity, trauma, resilience, climate change and other things as well. So it's really broadened out that scope of what people are working on. So I think that's definitely the direction that we need to be moving in, and what we hear from our local communities as well.
Jason, and there's some pretty compelling evidence in population health, around the importance of the wider determinants and how fundamentally important they are to work on, aren't they, Jason?
In the context, building on what Sarah spoke about, in the context of services that are trying to support people, we talk a lot in Newham about an idea that we're looking a lot through our centre of what we call ART, access, relevance and trust, and that the barrier for people's meaningful engagement and use of services are often because services don't think enough about those 3 issues. What are the barriers of people to the practical barriers that people have to access things? How relevant do they feel to people's lives? And how much do they trust that they're in there, that they share their aims and meaning? And I think the question really speaks to the relevance one. We're supporting a community that are hugely affected by the cost of living crisis and a housing crisis. how much is that on our radar? How much are we thinking about how that's affecting people's lives when we're trying to get them to engage with screening programs, immunization programs, healthy weight, or whatever it is? And that has all come from those conversations we've been having with our community. So really identify a lot with the question. I think that lens of relevance is a really important one.
Yeah, and I want to close the session out probably at 11, but and just jump in. No, jump in really quickly with a quick thing.
I was just going to say that, and that relates back to the question on sustainability and engagement. We need to make the engagement with our academy work, our research work, our partnerships work accessible, relevant, and trustable or trusted in that kind of work, not just as well as the work of services and support for people in their day-to-day lives. Thank you, Anne. And thank you to all of our panelists. Honestly, it's been fascinating to be part of the conversation. It's been a real privilege for me. I hope everybody of you that have dialed in and have enjoyed and got some real value from this discussion, some really practical stuff, as well as some of that really big picture stuff about how people are trying to move forward with real intentionality towards this thing that we might label academy, but turns out is different everywhere you go, and the journey is different. So thank you all for dialing in. Thank you all for your questions. There's a couple we didn't get to. Really sorry about that. Hopefully we've kind of answered the questions that you were holding in your head, as well as the ones you've posted. And really just to say, you can access other resources. We'll put up the links and things that came up in the conversations today, so you have that in your resources tab on the left hand side of your screen. Really looking forward to seeing you back here at 11:30 for the next session, and just invite you now to go into a bit of a break. And if you've made some connections and you've got the opportunity to do some networking, then you've got that to do now between now and when you rejoin at 11:30. So thank you all very much for coming. I really appreciate you dialing in. Thank you.